Onc Live Insights is a video editorial program produced by Onc Live.
The time to start therapy in kidney cancer is a very important question. Many kidney cancer patients have a very indolent disease from the beginning, and we have to be sure they progress before starting treatment. So it's recommended to have at least 2 scans 3 months apart before starting treatment each time we can, which means asymptomatic patients. And then if the patient is really having progressive disease, then we have to start first-line treatment. So we certainly look mainly at performance status outside of clinical trials. So we have a list of classical prognostic factors. Probably the most important one is performance status, the general status of the patient. So that's the most discriminant part of our choice. We also look at age and comorbidities because, of course, elderly patients with cardiac problem will be someone different to treat than young patients who are absolutely fit. But performance status is probably the most important one.
When we are confronted with patients with metastatic kidney cancer, we first have to assess whether there's really progressive disease and whether the patient really needs treatment. So in a patient who has, for instance, small lung nodules that are not progressing, people would tend to wait with the initiation of first-line treatment. However, if it's clear that there's some progression, and depending on the clinical condition of the patient, of course, we will decide to start soon with first-line treatment. And then we will take into account patient characteristics, tumor characteristics, the histologies, clear cell histology versus non-clear cell histology, but also the comorbidities of the patients. And I think nowadays, with new data emerging, we also have to take into account the patient preference. When deciding which treatment to choose for which patient, I think everybody of us first tries to categorize the patient into a specific risk group. We have Memorial Sloan Kettering risk factors that divide the patients into poor, intermediate and favorable risk groups, and we have also other types of algorithms that helps us to assess upfront what the a priori prognosis of a patient is. So based on that, we decide which treatment we will choose. There are sufficient data for patients with clear cell histologies. There are still little data for patients that have non-clear cell histologies. So the level of confidence about which patient to treat with what drug is much higher if a patient has a clear cell histology. So in principle, the phase 3 data are there for patients with favorable and intermediate risk categories as compared to patients with poor risk features, and we will choose between TKIs upfront for the patients with the favorable and intermediate risk group, and we tend to first choose temsirolimus for patients with poor risk features, because the data of the phase 3 study for poor risk patients, in essence, the ARC study was done with temsirolimus versus interferon. So most of us tended to use temsirolimus, but I must say that because of some limitations, temsirolimus is relatively easy to administer, but it's an IV treatment, and now with all the oral compounds coming up, doctors as well as patients sometimes prefer, or often prefer, depending on the situation in your country, in your hospital, to go for oral treatment. And I think that in real-world data we have sufficient evidence to show that also TKIs upfront in patients with poor risk features are effective drugs. When asked why you opt to treat patients upfront if they have metastatic kidney cancer, the answer is that you're really aiming for improved overall survival. And that's the primary goal of our treatment in first line. Of course, if patients have complaints that are related to the sites of the metastases, palliation of their complaints is also a major goal, but clearly overall survival is what we should aim for, and that's the primary endpoint, and that's the reason why we treat patients up front. And there's sufficient evidence from all these phase 3 studies and all the subsequent data that emerged since 2005 that you really have a gain in overall survival in patients who are treated for metastatic kidney cancer.
When we start treatment in a metastatic kidney cancer patient, you usually explain my patients that we are not going to cure them. We know that a few patients are going to be cured, probably 1 or 2%, but most of them will not be cured. So we explain that we are going to try to expand their quality, their life and their quality of life, which usually we do, but we should explain them that we are not going to cure them. So quality of life, how we are going to deal with the treatment is going to be very important.